And I'm going to share my screen. So tell me, can you guys see it? Can you guys see the case study?
Yes.
All right. I'll make it a little bit bigger. Roll it up. All right, so we have Mr. Smart that presents to the family physician some recent developments that they've had. The patient states he's been extremely tired. He's having trouble concentrating. Skin's dry and flaky. Nails are brittle. His hair's dry. Dull. It's been falling out in the shower. He's 8 weeks post-op from, oh, we did this one.
Yes, we did that one. We need to do 51.
We need to do 51. I'm like, this sounds familiar. Please. So let's go back to the drawing board. That's crazy. I'm like, this seems familiar. Why does this seem familiar? That would be because we did it already. All right. Let's try this again.
Miss Hudson.
Yes.
Before you start, there's a lot of background noise when you're talking and it's echoing.
Okay, so hold on 1 second. All right, so I've gone through and I've muted everybody except for myself. So if you're gonna talk, then you have to unmute yourself, or you can, there's a little chat button down low that you can use to send messages. And that way, that should help clear it up. So thank you for that. The other thing is there's a couple folks who haven't changed their email address to the DCCCD email. You've changed it in one area, but it has to be in all areas. Your ExamSoft, eConnect, eCampus, Exemplify. So you need to have all of those, you know, and I'm just naming a few. Your Lippincott stuff. The college only sends out emails to your DCCCD. So if you don't get it, you know, don't be mad saying you didn't get it.
Much better if I can get familiar with the way you talk. I need your permission to help.
Sorry about that. For some reason, Cortana just decided to kick in. So anyways, just make sure that you guys are turning things, you know, getting all your stuff taken care of. All right, now let me go back to this case study real quick and get the right one so we can talk about Sally Smith, because that's who this case study is all about, Miss Smith. And I will share my screen again. And there we go. All right, how's that? I think that's the right one. Let me make it bigger. Okay, so Sally Smith is newly diagnosed with type 2 diabetes. During the patient education, she asks the nurse, what should I do if I'm sick and I can't eat? Should I still take my medicine for diabetes? What would be the correct answer to that?
Yes, she should still take it.
Why should she still take it?
Because when a person is sick, the body can actually cause stress and produce more and higher glucose.
Okay. So there's two things here. When pediatric kiddos get sick, what happens to their glucose level? Does it go up or down?
I'm guessing it goes down.
It does go down. Kiddos have a higher metabolic demand, which means they're going to burn a lot more of, and their metabolic demand is going to be glucose. So they're going to burn a lot more glucose than adults. When adults get sick, their glucose levels go up. So in clinical, when you guys get to clinical next semester, then what you're going to see is more adults with hyperglycemia that don't have a diagnosis, but that's because of the stress of their illness. And that's the reason why they have it. It doesn't mean they're diabetic, but we know that diabetes causes delayed wound healing, right?
Yes.
Okay, so that's the reason why we want to make sure that they get better quicker, or, reasonably, and then they're out of the hospital, because the longer you stay in the hospital, the more prone you are to developing some type of hospital-acquired illness or infection. So when the body is ill, then the physical stress leads the body to release cortisol. So when that's released, then this causes the body to release your glucose. And where's your glucose at this particular time? Where's that glucose being stored?
In the liver.
In the liver as glycogen. So now the liver is stimulated to release the glucose stores into the bloodstream, which is the reason why it goes up. So and really what that is your body is looking at this illness as your fight or flight response. It is basically a sympathetic nervous system activation. So when that happens, then your body's now going to dump out glucose because it doesn't know what do we need to do? What is our stressor? So the body needs insulin to be able to use the sugar to provide the cells in the body with the energy the cell needs. So the only place in the body, where in the body is the only place that insulin is not used to get glucose into the cells?
Can you repeat that question?
So
Can you hear me?
we need insulin to transport our glucose, right, into the cells. Where in the body do we not need insulin? There's one spot.
The brain.
It's in the brain. So we don't need insulin for glucose transportation in our brain. Okay?
Yes.
All right. So what management strategies should the nurse provide the patient to deal with sick days? What should we tell the patients?
Well, they should be encouraged to have as much rest as they can
Okay.
in order to facilitate, the body being in
Mm-hmm.
a relaxed mode so as to reduce the stimulation or the secretion of cortisol.
Mm-hmm. Okay. So should we tell them to stop taking their oral agents or their insulin?
No.
No, but we need to make sure they understand that they should take those when they're able to eat. So think about the role of insulin. It's designed to keep your glucose levels lower, correct? So if you take it and you haven't eaten, then you're going to put the patient at risk for what?
Hypoglycemia.
Exactly, or insulin shock. So now we're talking blood sugars in the 30s and 40s, and that is not what we want to have happen. Okay. The other thing is if they're nauseated, they're vomiting, then they need to call the doctor for dose changes. So ask them ahead of time, how to reduce dosages when sick. So those are things we want to educate our patients about. When you're sick, then you need to, find out what would be safe doses to give yourself. And the dose needs, because the dose will need to be lowered. You can't take the same dose. Should they change their diet when they're sick? Or should they try to maintain their diabetic diet if they're able to?
They need to maintain it.
So if they're able to, they need to maintain their diabetic diet. And if they can't tolerate and eat solid foods because they're nauseated, then they can do non-caffeinated drinks with carbohydrates like gelatin, juices, Gatorades, And should they just gulp it or do sips?
Sips.
They should do sips, okay? So with the sips, every hour while awake, and if they don't have carbohydrates in it, like your broths and your teas, those are some other ones that they can also use. So water, broth, and teas, they're liquids without carbohydrates. If they're unable to drink any fluids, then they should call the physician immediately, because depending on which type of diabetes they have, that's going to be a concern. So what is the pathophysiology behind type 1 diabetes?
Well, type 1 will be a situation where, like, the pancreas do not secrete insulin at all. So the individual in this case would need to receive a supplemental insulin in order to, drive in the glucose to the blood and to the cells, rather, where they will be needed for energy. So I would say that is it's a permanent condition that cannot really be reversed.
Okay. So what cells in the pancreas makes insulin?
That would be the beta cells of the islands of Langerhans.
Okay, so it's the beta cells. So here in type 1, that would be your insulin-dependent diabetes, right?
Yes.
So those cells do not make any insulin. And it could be an autoimmunity problem, so that's an autoimmune condition where the body doesn't recognize those cells as self. Either way, we don't get any insulin made. So that means that person will be on insulin lifelong, right?
Right.
What are the 3 Ps? You can't answer, Oki. Sorry.
Polyuria.
So polyuria,
Polydipsia.
polydipsia, and what is polydipsia?
It's thirsty.
Good.
Excessive thirst.
They're excessive thirst. And what's the last one?
To poly too, but I forgot.
Polyphagia. So polyphagia. So you got to know those polys. Make sure you understand that. So the pancreas not only secretes insulin, but it also makes glucagon, and it also makes somatostatin. So it's 3 different hormones that the pancreas makes. And that's from the endocrine side. And we have exocrine, which is, for the pancreas and digestive enzymes, etc. All right. So the folks that have insulin-dependent diabetes, they are at risk for what complication? What complication are they at risk for?
Ketoacidosis.
Say that again.
Ketoacidosis.
So diabetic ketoacidosis, how does that come about? What is the body now using instead of carbohydrates?
Fats.
It's using fats. And because of that fat, we're creating ketones, which is an acid, and that's not normal, correct?
Correct.
Okay, so when the body can't get the energy from the glucose, then it starts to use the fat stores, and that will create ketones or ketosis. So, those are things that we will be looking for, that diabetic ketoacidosis. Now, does your blood sugar need to be 1,000 in order to have DKA?
No.
No, you can have DKA and it can be 350. It's about the ketones. Now, one of the hallmark signs they talk about, or a couple, will be Kussmaul's respirations. What is that?
It's rapid deep breathing.
So it's rapid deep breathing. So, you know, what is the other sign?
Fruity breath.
Okay, and truthfully, people say, oh, it smells like juicy fruit, this, that, and the fifth. The truth of the matter is it actually smells like old behind. So it's not even, it's like stinking, like old sweat. It just smells stinking. It's not what people think it really is. So if you ever smelled it, you would know that it's not juicy fruit, okay? The other thing is, why do we end up with the increase in respirations?
I would say that the body in that case, it's in a state of, it's in acidotic state. So the compensatory mechanism, excuse me, which normally will be the lungs, will kick in order to eliminate or create a homeostasis by eliminating the acidic or the acid or the carbon dioxide, in the body.
Okay, so why, but we are doing it to try and do what with the glucose? Not the glucose. What are we trying to do with the ketones? Blow that off?
To get them off the system, yes.
So that is how our body tries to get rid of the ketones, is by creating these rapid Kussmaul's respirations. Okay.
Okay.
All right. So speaking a little bit about insulin, remember I said you need to know what's your fast acting, your rapid acting, your intermediate, your long acting. And there's, if you've been in nursing or in healthcare for a while, then you would understand that, things as far as there's different products. We now have things like Levemir, right? And how is that delivered? How do we deliver Levemir?
Isn't that IV?
Nope.
Oh.
You talking about the pen or the injection?
It's sub-Q.
It is sub-Q, but it's actually a pen, and it is an injection.
Okay.
Where before we were using insulin
needle.
It comes in.
Yeah, it comes pre-mixed.
It's already mixed of what you need to do. So basically, if you need to get 15 of Levemir, then you would turn the dial to 15, or you would turn it to 16 or 17, depending on the situation. But you got to prime the needle because you need to make sure the patient gets 15, right? So if you only prime it to 15 and you have to prime the needle, will the patient get 15 or will they potentially get 14 or 13?
13.
14 or 13.
14 or 13. So that's why you take a little bit extra out. But once you prime it and then you put you dial it back to your 15, clean your site, pinch the skin. And is this going into the muscle or the subcutaneous tissue? Subcutaneous tissue. And you go ahead and press the needle, put the needle in, and you hold it until the dial spins all the way back to 0. And then you actually hold it for an additional 10 seconds to make sure we got it all in. Then we take out the needle, disconnect it, put it in the sharps container, and we've delivered our dose, right?
Right.
So basically what I'm saying is pay attention to if you're going to be giving it through the pen or if it's actually, something you have to draw. And can you give insulin by yourself?
No, you have to have a nurse to witness.
You need to have another nurse colleague verify it before you even pull it out of the vial. And you will give patients that are insulin dependent, you would give them, insulin based off their sliding scale. Okay. So you need to understand what your sliding scale is and how to deliver it. And regular insulin is fast acting. List Pro is fast acting. So you need to understand how they operate. Once you put it in that subcutaneous tissue, can you suck it back out?
No.
Nope. Once it's in, it's in. That's the one that you got to understand that. So that's why, and insulin can kill people.
Yeah.
Because it can wipe out their entire glucose stores. And if your brain doesn't have glucose, it's not going to work. So you got to think about all of those components. So, finger stick blood sugars, and we're going back to the scenario, the urine ketones, blood ketones, well, it's really urine ketones, not blood. Urine ketones, you need to check that every 3 to 4 hours. Now, if you've been in nursing a while, a good 15, 20 plus years, then there used to be a time that they had these little sticks that you would dip it down into the urine, and you would sit there and look at the strip and turn the bottle to see where it was, and this, that, and the fifth. Now they do UAs and tell you, what you have. So, make sure if you have any abnormal results, what are you going to do?
Call the doctor.
Call the physician.
Tell a physician. So if the patient has a fever that's more than 3 days and it's greater than 101, then this is something, this is not DKA only. So diarrhea of more than several stools, and it really depends on how much, because really they're going to get, what's your concern with the diarrhea, even the vomiting? What's your concern?
Dehydration.
Dehydration, absolutely. So so make sure we're reporting that. If they have a fever, they could actually have some other infection. So this is the reason why we want to call the physician. So if they're coughing and you want to see if it's productive, right? What kind of color, consistency, make sure there's no blood in it. So those are things we want to look at. All right, so we have a different person, Mr. Thomas, 26-year-old, type 1 diabetic.
Sorry, Ms. Hudson. Sorry to interrupt you. Still on the prior case study we did, will it not be a top priority in the case of a patient who is diabetic, type 2 diabetic, and is not eating, to kind of do a regular check of the blood sugar?
Okay, so if you have a type 2 diabetic, a type 2 diabetic is an individual who makes insulin, but those receptors are dysfunctional or don't work appropriionally, or they don't produce enough insulin. Does that make sense? So either the receptors are dysfunctional, or they don't make enough. So they make some, but not enough to handle the job of what they need.
Right.
So with those individuals, we focus on, because diabetes is a carbohydrate metabolism problem. Mm-hmm. So we do focus on them eating things that are low glycemic, things that don't convert over to glucose quickly. So that would be your pastas, your rices, potatoes, things of that nature. So more fruits and vegetables, leaner meats, those would be things you would actually give them. But if you have a person that's a type 2 diabetic, you would really still kind of follow the same process. You want to make, if they can eat, because if they're not eating, they're going to become hypoglycemic too.
Right.
So that's why I said oral agents and or insulin, they need to be able to eat before they can take those. So they would need a little bit of an adjustment. Okay. But you can't it's kind of hard or counterproductive to give a person an oral agent if they haven't been eating.
Right.
So as nurses, those are, just because it's prescribed, you have to be thinking about, is this the right thing to do at the time? And if it isn't, then why are we doing it? So the doctor can order it all they want to, but you're the person that's going to be giving this order. So you need to ask yourself, is this, this patient's been vomiting, I'm going to have them swallow a pill? No, not if they're vomiting. Because what's going to happen to the pill? They're going to vomit it back up. So let's try to get that part under control, and then advanced diet is tolerated, still monitoring blood sugar levels, etc. Make sense?
Sure.
Okay. All right. So most type 2 diabetics, since we're talking about it anyway, they're going to start with diet and exercise. If they do diet and exercise, hopefully that should help maintain their blood sugar level. And if not, then they'll add an oral agent. A type 2 diabetic, can they become a type 1 diabetic? Can they end up on insulin?
Yes.
Absolutely. But if you are a type 2 diabetic, what is your biggest complication with type 2 diabetes? For type 1, it was DKA. For type 2, what is it?
Cardiovascular problems.
No, besides that.
Renal failure.
Besides that.
Hypoglycemia.
It's hyperosmolar or hyperglycemic hyperosmolar non-ketosis. Remember that HINC? HHNC? They say it's a coma, but it really isn't a coma. So your type 1 folks are going to develop DKA. Your type 2 people are going to develop HHNC or HHK. That's how it's actually in your Lippincott book. So you got to be mindful of that process. Now, overall, diabetes as a disease, cardiovascular compromise, they can have a stroke, they can have a heart attack. Yeah, all of those things are definitely possible. They can end up with diabetic retinopathy. They're going to develop neuropathy. And if they actually take some vitamin B complex, so all those B vitamins, it will actually help with their neuropathy because that helps with promoting healthy nerve cells. So that's an option that could be if your physician practices alternative therapy. But with HHK, the hyperosmolar hyperglycemic non-ketosis or a syndrome, they can die from severe dehydration. Okay. So that's the difference between the two. With DKA, the cardiac part is going to be due to the fact that it's a potassium-related dysrhythmia. If they have all the polyuria, polydipsia, polyphagia, that polyuria, the potassium's going out with that urine. All right, so we ready to go on to Mr. Thomas?
Yes.
Okay, so again, type 1. He was originally diagnosed at 14. Type 1 is also known as juvenile diabetes. I believe your book says from 1 to 30, and then type 2 is 30 and above. However, we have type 2 diabetics that are younger than 30, and especially with a lot of childhood obesity is the reason why we see it sooner. So he manages the disease with an intensive regimen of insulin injections, but he's type 1. He is employed as a school teacher and a soccer coach. He presents today with a 2-day history of vomiting and diarrhea. He's been closely monitoring his glucose levels. He's using regular insulin for his glucose. He's only been able to tolerate liquids like Gatorade, but today he can't tolerate that. And he comes to the clinic for evaluation for possible DKA. So describe the pathophysiology of DKA and why it occurs in patients with type 1. And we've already kind of talked about that.
Yes.
Based on the diagnosis of DKA, what assessment findings does the nurse correlate to this disorder? So hyperglycemia, the nausea, the vomiting. And although the serum levels are elevated of the glucose, the cells are actually starving because the glucose cannot be used secondary to a lack of insulin. So that's his whole issue there. C, the physician orders a complete metabolic panel. Glucose is 425. Other lab values are serum sodium at 152, potassium's 30. Are we good or bad here? And BUN 64. What is your assessment of these results?
Kidney function's bad.
I agree.
Sodium levels high.
Yep. Sodium's high. Remember, they're going to be severely dehydrated. So your body is going to be trying to hold on to every ounce of liquid it has, which means you probably won't be doing a whole lot of, well, you're going to be peeing, but you're going to be flushing out.
Right.
So our glucose is elevated, which is consistent with DKA, right? And the body's inability to use the glucose. We have something called osmotic diuresis, and that's because caused by the hyperglycemia, and we probably have glucoseuria as well. And we do, because once your blood sugar gets above 180 milligrams per deciliter, then the sugar it spills over into the urine and you pee it out. So now we have a loss of fluid through the kidneys, and hypernatremia results. So the body attempts to kind of buffer the system, the acidosis, by moving your hydrogen ions into the cells, which now means if hydrogen is in, the potassium's leaving the cell, which means we're going to pee it out because it's going to be lost in the urine. So now we have a total loss of potassium in the body. This is what's going to set up those cardiac dysrhythmias. And they would be hypokalemic. So why is it important for him to continue to take his insulin even though his oral intake is decreased?
Yeah, because the cells need to be fed in order to maintain an optimal body function. So without the insulin, there's no way that nutrition will be delivered into the cells.
Okay. Anybody else?
Because its glucose level is still too high, and the body needs to find a way of normalizing. So we have to bring it down.
All right. So in DKA, it is a stressful event. Cortisol secretion is going to happen as a result of the stress response. So that's going to be increased, which is going to cause your glucose levels to increase. Therefore, we will probably have to give him what to help normalize the glucose levels.
IV insulin.
So he's going to have to receive insulin. All right. Questions about DKA, HHK? You kind of know what your cells are. You know, remember those HESI exams, those HESI A2 exams? Where you had to learn all these little components. That kind of helped you kind of put these pieces together. No, maybe?
Yeah.
Well,
So am I kind of tingling?
we are short of words at the moment. To the almighty Hesi.
Well, I'm just saying, you know, food for thought.
Okay, Steve, now we're talking about the Hesi.
I'm just trying to stimulate those brain cells.
Yeah, is it similar to the Hesi A2 or is it a completely different standard?
No, basically, your anatomy and physiology. That's all I'm really trying to say. So if you have, you know, you're going to have to go back and review your some of your anatomy to kind of understand and put some of these pieces together. But Lippincott does do a good job of it as well. So if you are reviewing that, you know, because it kind of walks you through, that process.
Okay.
So hopefully you guys are, you know, looking at that, so that way you'll know what to do. But right? No,
Yes.
maybe.
Yes.
You guys are like,
Yeah.
like, holy cow, Shazam. I mean, it is a lot. It's probably more challenging for you all because some of this knowledge you may not have used in a while.
Sure.
So you just have to kind of go back and get things situated in your mind, so that way you
Okay,
can understand the process, because we're moving away from that disease management process to more concept based. Like, how does this relate to the concept? So I've talked about nutrition. I've talked about a little bit of thermal regulation. That it's related to other diseases. We've talked about gas exchange with the Kuhl's-Moll's respiration. So all of those pieces are being tied in to, into this process.
so quick question. Sorry. I know we have the HESI at the end of the semester, at the end of this semester, right? And
Right.
my question is the HESI gonna consist of all the concepts that we have done this semester, or is just everything?
Okay, so when you take HESI at the end of this semester, it's going to be everything you covered this semester,
Okay.
including P&C.
All right. Okay. Okay.
Does that make sense?
Yes, it is.
Okay. So as long as you are doing that, then you should be A-okay. But those raising the bars definitely will help you. It's going to be kind of hard to, oh, hold on. All right, there. I stopped sharing my screen. It's going to be kind of hard if you haven't been working on it. Does that make sense? I can't hear you.
Yes.
Oh,
Yes, it is.
Yes.
but how many of you all have been doing the raising the bars?
I have.
I have.
Trust me, I highly suggest you do it. They won't be in all semesters. You'll see them this semester. You'll see them next semester. You will not see them fourth semester. Okay. All right. So tell me what you know about thermal regulation. What have you looked at regarding thermal regulation?
That's the body's way to regulate temperature.
Correct. It is the body's way to regulate temperature. So speaking about temperature, what would be a normal temperature?
98.6.
98.6. Yeah, it's nothing, we're not talking about anything that we don't know already. You're like, is this a trick question? So regular temperature is 98.6. All right, so let's look at when we are considered to have hyperthermia. My phone, there we go.
Isn't that above like fever? 101,
I can barely hear you.
Isn't that above like a high grade fever, like maybe 103?
Okay.
Okay.
So when do we usually have hyperthermia? Do we just poof, we just get it? What's going on with our bodies?
It's trying to fight some form of a foreign object or like an infection.
Right. So there's some type of illness that's going on, and this is the body's way of responding to the illness. So, you can have heat rash, you can have heat cramps, you can have heat exhaustion, and the most severe form would be what? Heat stroke? Okay. So with a heat stroke, the thermoregulatory portion of the body, which is the hypothalamus, it cannot function. It's completely failed. And the body's temperature at this point is 100.6. Is that normal?
No.
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 So with there's different types of heat stroke, and I'm gonna back it up just a little bit, because if you understand how many the different types, like what heat cramps are compared to heat exhaustion compared to heat stroke, it'll all make sense. But we'll start with heat rash. So usually this happens when the secondary to blocked sweat ducts. So your sweat gets trapped, or perspirations gets trapped, and then these are usually some superficial changes to the skin. With exposure to heat, the body normally regulates the temperature through evaporation. So 30% of the body's heat loss is done that way. And most common place for you to lose heat is where?
The skin.
But where specifically? Your head.
Okay.
So the other form, or another way you could actually, try to regulate the heat, is by vasodilation. So when the heat is generated faster, or is gained by the body faster than it can dissipate, then our thermoregulatory mechanisms are going to kick in, or they actually become more stressed and they eventually fail. So once our thermoregulatory system fails, then we become a lot more hot, right? Or hyperthermic. The other concern we have to worry about is cerebral edema and cerebral vascular congestion happening when that thermoregulatory system fails. And our cerebral perfusion pressure then increases, but our cerebral perfusion, then the pressure increases, but then it will decrease immediately after. So it's very important that if you have someone with any type of environmental emergency from the heat side, that we actually cool them down. Now, you can't cool them down too quickly, because if you cool them down too quickly, then what happens to the muscles?
Constricts.
Not constricts, but you're going to shiver.
Yeah.
And shiver increases
increases the heat.
Increases the heat. So now this is a counterproductive process. So if we're counterproducing what we're trying to eliminate, then that's not good. So you just can't throw somebody in a big whop of, ice water, and then they start shivering, and now we're creating more heat, and they can end up with a seizure, right?
Mm-hmm.
So causes of hyperthermia, dehydration, that can happen. Certain drugs like our thiazines, that can happen. Cocaine, amphetamines, stopping your Parkinson's meds quicker or just abruptly. Being out in the environment. So, we live in Texas. It's not uncommon in the summer to have 100+ degrees. Doesn't have to be 100 degrees though. What really makes it unbearable as far as the temperature during the summer? Is it the temperature, or is it the humidity?
Humidity.
It's the humidity. So you can have 90-degree weather, but if you have 100+, humidity, that makes it unbearable, because that's real thick air that really doesn't move, right? Heart disease, infection, these are all causes of hyperthermia. So salt depletion is usually the first thing that happens. How do you know? Think about when you exercise, and if you don't stretch your muscles and drink Gatorade afterwards, what may happen to you?
Cramp.
I didn't hear that.
Cramping.
Okay, so you get a Charlie horse or a leg cramp, right? And
Yes.
then, usually you get up and hopefully drink some Gatorade, replace that potassium. That way you can end up, your cramp should go away. So should you stretch your leg? Should you flex your foot or extend your foot?
Extend.
Shouldn't you flex it? Like, bend it back?
Yeah.
Because if you do that, then wouldn't it stretch this here?
Yes.
Okay, just checking. So as we go through and we talk about these heat emergencies, the worst case scenario is a heat stroke. It is one of the 3 leading causes of death in sports and people who work outside, especially in the summer months, or if you don't have AC, so if they turn your AC off, that can also be another reason why. And it is, you see more deaths in males than women. Why? How many women you see
Higher
working
body
outside?
demands for men.
You see very few women working outside. Okay. So this is a salt water imbalance. So they can go into hypovolemic shock, cardiogenic shock, respiratory alkalosis. They can end up with acute kidney injury. So anything that's related to dehydration are things that can happen. Cardiac dysrhythmias, rhabdomyolysis, depending on if we have muscle injury. So we want to be mindful of that process. So our body usually, we have a heat rash, again, it's from those blocked glands. Heat cramps, usually your larger muscles are kind of involved in that as well, but you end up with like a leg cramp, so that tells you that you have an electrolyte imbalance, because that's what it is. So if you drink Gatorade or K10 or something with an electrolyte replacement, you should be A-okay. Are you still sweating in heat cramps, yay or nay? Do you still sweat when you have heat cramps?
Yes.
Yes, you do. All right, so now we're going to move to exhaustion. Usually with exhaustion, this is where you start seeing nausea and vomiting. If they're vomiting or nauseated, should we give them anything by mouth?
No. No.
No, we should not. And this is where they have that cool, moist skin or clammy skin, because they're sweating. They still have the ability to sweat, but it's going to be kind of warm. They could have headache, they could have fatigue, but now we need IV fluids to replace the loss. So this is where we're going to give them like sodium chloride. Okay. With heat stroke, their skin's going to be dry and hot or arid. Are we making sweat at this time?
No, the body is in shutdown mode.
Here we've had a thermoregulatory mechanism failure, so no. So we have, sweating, but they're dry. We have warm skin, then we have that moist skin, and then we have that arid skin. Does that make sense? So we go from heat cramps to heat exhaustion to heat stroke. But as we move further to heat stroke, our skin is hot and dry. It's not even warm anymore. It's hot and dry, hot and arid. So exposure to high temperatures and humidity without any air circulation is the reason why. Blurred vision, confusion, they could have hallucinations. A lot of muscle cramping is going to be what you're going to see. Okay. Rectal temperature. Why are we doing rectal temperatures?
For the core temp.
Core temp is going to be about 104 at least. Diaphoretic, red, gray, tachycardic. Why are we tachycardic?
Dehydration.
Because of dehydration. And it's actually the earliest sign of what? Shock. So blood pressure may be slightly elevated, but it's going to decrease as this persists. Tachypnea, dyspnea, changes in LOC. So all of those are things that may happen to your patient. Now, as this continues, we're going to move from that agitation to somnolence to seizure to coma. We're going to move in that direction. Okay. They can have hematuria. The kidneys are going to shut down. All of those things are going to start happening. Muscles will become more flaccid. Their respirations will start to change because literally the brain's cooking. Okay. With heat exhaustion, we still have time. Our skin will present with that shock state. So we got to make sure we're paying attention to those cues. And if you're looking at cues, that would be that cool, pale, clammy skin, which is that moist skin. Tachycardia, increased respirations, that would be that component. And they're still sweating. Heat stroke, we're not sweating anymore. Heat cramps, muscle spasms, usually in the legs, chest, and belly. Those would be your 3 primary areas. So what type of labs should we get on these folks? What would be some good labs?
CBC.
CBC, okay. So, they may have some leukocytosis or, thrombocytopenia. What else?
Metabolic panel.
What would be my top lab?
UN.
Potassium.
UN.
I would get a
Electrolytes.
chem panel.
Yeah.
So whether that's a chem 6, 10, 12, 22, whichever, that's fine. But what am I looking for in that? I'm looking for increased sodium and decreased potassium. And that's going to be initially. But as things continue without treatment, then we're going to be looking at hyperkalemia. We're going to be looking at our calcium and our magnesium levels because they're going to actually go down. With heat stroke, I'm going to be looking at liver functions because now, we got a lot of problems here, right? So I'm going to be looking at that electrolytes to make sure, we're A-okay. What about a UA? How would a UA be helpful?
Make sure that they don't have a UTI.
Not necessarily a UTI, but that they don't have protein in the urine. We're going to start losing some things. BUN, I'm going to check that to make sure, my kidneys are working. And I'm going to check lactic acid levels because sometimes they're commonly elevated when you're looking at heat stroke. I'm going to make sure they don't have any pneumonia or pulmonary edema. I'm going to check their EKG. Anything. So what would be our treatment form? Whether they have cramps, exhaustion, or heat stroke, what are we going to do?
IV fluid.
IV fluids. We're going to put them in a cool environment. We may do ice packs to like the axilla, the groin, the neck area, but we're going to continue to monitor temperature, core temp, remove the clothes. We're going to prevent shivering because we've already said that's going to make it worse, right?
Yeah.
Try to lower the body temperature. Make sure we use some cooled oxygen, a cooling blanket, some hypothermia blankets. We're going to support the respiratory and cardiovascular system. And because of all this drama, we're going to make sure we don't cause any clots. So is heat stroke a medical emergency?
It is.
Yes, it is. So we need to try to reduce that temperature very quickly. So I had one, I can recall one patient that was high on cocaine and his core temp was 107. He was running through the streets of Dallas, butt naked, and it was 100+ degrees outside. He was extremely hot. So, anybody convince you to do drugs, you tell me you don't want to be like that. If your patient has an alteration of mental status, are we going to give them anything by mouth?
No.
Can't. Because now, what if they aspirate?
Yeah.
Should we give them any coffee?
No.
Why not?
Aspiration.
Yeah. That would make it worse.
What does caffeine do to the vessels?
It's
Dilates.
constricts them because it
causes vasoconstriction. So we don't want to do that.
and the stimulant.
Right, it's a stimulant. So we're trying to keep things cool. All right, so we want to make sure they're resting. So what kind of medications could we do for a heat rash? Most folks probably put powder on it, but how about some calamine lotion?
Can you do Benadryl?
Lanolin, some lanolin, that'll be a good thing to do. For heat stroke, we're going to do oxygen. We're going to do fluids. We're going to try to suppress shivering during that rapid cooling period so we can give them chlorpromazine. We can give them benzodiazepines as well to help control seizures and reduce agitation. Sodium bicarb if they're acidotic. And we may end up giving them an osmotic diuretic to promote diuresis to help treat their acute kidney injury. So there's a lot of different things we can do. We can use spray them with cool water and put a fan on them, right? Cool IV fluids, cool gavages, things of that nature. Anything that's cooling that can help get that temp down. And that's pretty much what we did. We gave the guy cold IV fluids. We flushed his NG tube with cold water, things like that to help bring the temp down. Make sure IVs are patent. This is one of those times where, you don't want to say, I think it's in, I hope it's in. You want to know it's in. A lot of things are riding on that. Should we give him a Foley?
Yes.
Yeah, you don't want to peeing in the bed because you're about to give him a bunch of fluids, right?
Mm.
So yeah, that would be something good to do.
Okay.
Anything else that you can think of? Like, what if you have a person that's not so critical? What can you tell them, like discharge planning wise?
Avoid being in extreme temperatures for long periods of time and encourage them to drink plenty of fluids.
And more specifically, make sure you have some electrolyte fluids, right? So some Gatorade out there, some water, you're going to have to drink it a lot more, especially if you're out there. Try to find a cool environment every now and again to kind of be in. So that way you're not, you're not being exposed to the extremes so bad. All right, what is malignant hyperthermia? What is that? Is that a severe life-threatening process? How do people get it? So I think you guys had a PowerPoint over this, right? Did you not? You don't recall? It got awfully quiet in here.
I can remember that.
I mean, like, I could literally hear a rat piss on cotton right about now. It's just like, what's going on?
I can't recall that for now.
Yeah, there is a PowerPoint,
Mm.
and it talks about malignant hypothermia. And it's usually because of a reaction to inhaled anesthetics. Does that sound familiar?
Yes.
So any inhaled anesthesia gases like halothane, or to a muscle relaxant like a nectine, you can develop severe malignant hypothermia. So the body temperature increases very, very quickly, a lot of muscle contractions, and you got to be able to, recognize that very quickly. So it can be also caused by a rare inherited disorder, but there's an error in the regulation of your calcium in reaction to a triggering anesthetic agent. So people going for surgery and things of that nature. So this usually occurs in individuals with certain genetic defects that affects their musculoskeletal system. So the calcium regulation error leads to an intracellular hypercalcemia. And because of the defect, the concentration of the calcium in the muscle cells increase, and now we end up with muscle rigidity. So volatile inhaled anesthetic gases like succinylcholine, halothane, isoflurane, these are, and depolarizing muscle relaxants, those can cause an individual to have malignant hypothermia. Men are more susceptible than women. They can go into cardiac arrest. They can have compartment syndrome. They can end up with an amputation, heart failure, rhabdomyolysis. These are all severe complications that can happen related to that. If they've had a previous episode, then they're at risk for having it again. Okay? So it's going to vary by patient. However, you will start to see things within an hour of anesthesia being stopped. So their body temperature goes up, they're tachycardic, tachypnic, their blood pressure's all over the place. Basically meaning it's up, it's down, it's down, it's up, it's not stable. So that's what they call labile blood pressure. There's an abrupt or an increase in their end-tidal CO2. What is that? What is end-tidal CO2? So remember, we blow out CO2, right, when we exhale. So if we have an increase in CO2, then that means it's being retained in the body. Normal CO2 is 35 to 45 millimeters of mercury. So if we usually with malignant hyperthermia, it's like in excess of that for sure, around the 100 range and higher. So our clinical manifestations would be high CO2 levels, rapid rise in temperature an hour after discontinuing anesthesia, hypertension, and increased muscle contractions. Okay. So we want to be looking for that. We need to respond quickly. Stop the oxygen for sure, or not the oxygen, but the inhaled gas, IV therapy, quick cooling with ice, and then the methods to treat malignant hyperthermia. And what drug should we give them? It's only one. It's the only effective drug. What is it?
I'm sorry, can you repeat that? I'm sorry.
There's one drug, and there's only one that we can give these patients. And I'm asking you, what is it that we can give them? And this is to help prevent them from dying. What is the name of that drug that we will use for a minimum of 24 hours post-operatively?
Is it a prednisone
Not prednisone.
or epinephrine?
Oh no, we give them epinephrine, we're gonna for sure kill them. All right, so let me tell you a little bit about epinephrine very quickly and why this would not be the one. So remember, we have hyperthermia and we also have hypertension. Now, just briefly go back to lecture on Tuesday when we talked about hyperthyroidism. Remember, everything is fast and elevated. So what happens? Epinephrine is adrenaline. So when you have adrenaline, what happens to your body? Everything goes up. So we would now basically be adding fuel to the fire. That's what we would be doing. All right. So we don't want to do that. However, we want to give them dantrolene, DANTROLENE, dantrolene sodium.
Okay, sodium.
Dantrolene sodium. This is all in Lippincott, trust me. And when we give this to the patient, we're going to give it to them for a minimum of 24 hours post-op. We're not going to give them any type of calcium channel blockers because these drugs interact negatively. So if the patient's on a calcium channel blocker, they're going to stop it. Because if they give them the calcium channel blocker with the dantrolene, then the patient's going to end up with a massively high potassium level. And we already have that problem. So we don't need to add more fuel to this fire. We don't need to do any more. So what we're going to do to try to get that the potassium down is give them regular insulin and D50. It will shift it out of the blood. So other things we can do is give them sodium bicarb for the acidosis and give them some mannitol to help maintain adequate urinary output, or Lasix, because mannitol is more of an osmotic diuretic, and then Lasix is a loop diuretic. But overall, we're not giving them anything by mouth. We're keeping them stable. We're going to give them the dantrolene. We're going to monitor their cardiac status. We're going to put them on oxygen. They will probably have to be ventilated, which means they're going to have an ET tube. So whatever the agent is that's causing the problem, they'll have to stop that immediately, monitor temperatures. We're going to be doing cooling mechanisms. Or cooling measures like oral gastric lavage, ice packs, cool IV fluids, hypothermic blanket. Then we're going to make sure, because we're cooling them down, we're not causing blood to pool and cause clots. So we're going to be putting them on some type of thromboembolic prophylaxis. And they probably need to do some genetic testing to see if they have this particular gene. But anyone that has a history of a heat stroke is at risk for this as well. And they will end up with myoglobin in the urine. So that's our lab values will be a urinalysis, an ABG, and we're really getting that ABG to see what those CO2 levels are. We want to make sure that they're within normal range, which is 35 to 45. If it's greater than 60, we're in trouble. Okay. Potassium levels, we're going to get a comprehensive metabolic panel, but we're specifically looking at calcium and potassium because they will both be elevated. We're looking at our creatinine and our BUN because those levels tell us how our kidneys are working. And CBC, we want to also get looking at myoglobin levels blood-wise. So that's our whole process there. Anything else you can think of about malignant hyperthermia? So look at those PowerPoints. Don't ignore them because you should be doing that part before you come to class anyway. That's part of that studying process. Printing off your PowerPoints, taking notes, making notes based on what you read in the book. So all of those will be things you want to be paying attention to. Okay. Any questions about malignant hyperthermia? All right, since we're on the hypothermia side, what about kiddos? What's the one thing that can happen with kiddos in high temperatures?
Seizures.
Febrile seizures. And usually that's because even though the kiddo had a fever, mom or dad may not have did the alternate of the Tylenol and the ibuprofen, or they didn't give them enough. The weight, because it should be all weight based. And we got to make sure we're telling them about that. Most people, when the baby has a fever, they bring them in, they look like little Eskimos. So does that help the fever or make it worse?
It makes it worse.
It makes it worse. They're all bundled up. So you're just keeping that heat in. You got to let some of that dissipate out. And they have an immature thermoregulatory system. They do not tolerate extremes of heat or cold. Same thing like elderly. They do not tolerate extremes of heat and or cold. So their body temperature has to be right. Okay. As elderly get older, they're, you know, they may have cold sepsis. They may not ever have a fever. So that's, you know, something you got to keep in mind about that. So if they have something like pneumonia or a urosepsis, they're going to have what's going to be their hallmark sign is a alteration in mental status. So it's not going to be fever. So if you're looking for fever in an elderly person, you're wasting your time. All right. Other one was cold injuries. So they do have a hypothermia PowerPoint out there. There's different types. You know, you have frostbite, you have frost nip. There's different types of cold exposures or cold injuries. And you can have overexposure to cold air. I mean, heck, just last couple of days, these temperatures, I can't even remember if it was Friday or yesterday. Either way, you go out there and it's like, you know, you can have, the temperature can be 32 degrees. But if your wind chill factor is sub-zero, you're going to freeze. Plain and simple. So it doesn't mean that you can't freeze at, you know, at any other temperature, but it's usually that wind chill that'll grab you real quick. It's that when you walk out and your eyes just start batting because you're like, okay, I got to adjust. So it could be a superficial freeze. It could be a deep freeze. And if it's a deep freeze, it can definitely lead to what? There's
Thrombolytic.
If you a deep freeze, meaning the tissue is frozen below the layer of the skin.
You can have a thrombosis, maybe.
You can end up losing the limb or developing gangrene before you lose the limb. So you can have a gaseous or liquid. You can have a dry or wet gangrene. So normal body core temperature for hypothermia is less than 95. Core temp between 90 and 95 is mild hypothermia. Moderate is between 82 and 90, and severe is when the core temperature is less than 82. So you can have crystallization that happens to form within and around the tissue cells. So the membranes will rupture, and this is in frostbite. And your enzymatic activities are interrupted. Your mediators like histamine, your prostaglandins, bradykinin, they all get released, and we end up with tissue ischemia, and necrosis can happen. So here the balance between heat production and heat loss has been impaired. And you usually see this when you're exposed to cold water or a cold environment. Now here's something to put into perspective. So say for instance, you're, you know, out at the beach or whatever, or you're boating and somehow the boat capsizes for whatever reason, and you're out there in that water, you can develop hypothermia, even if the water wasn't cold initially. But just your body being in that water, there's going to be a lot of transference of heat. You're not going to be getting a bunch of heat in. You're going to be losing heat. So the cell membrane there becomes altered. There's a lot of intercellular fluid shifts and changes. Your electrolytes are all out of whack. There's an imbalance there. Your enzymes are dysfunctional, and most people can end up dying, even if the water started out at 80 degrees. Does that make sense? So, other causes of hypothermia is, you know, large amounts of cold blood. Usually we don't give blood cold anyway, hopefully not, or too cold. Prolonged exposure, so all of your, like if you're your football stadium, if it's an outside and not enclosed, if you are homeless, and then being in freezing temperatures. So lack of insulating body fat. So those are risk factors. If you're super skinny, you don't have enough, you know, cushion. Cardiac disease, diabetes, peripheral vascular disease, all of those are going to be risk factors for cold intolerance. Hypothyroidism, because they don't tolerate extreme, they have cold intolerance. Altered mental status, previous cold injuries, So all of those cold weather sports, so all of those can lead to hypothermia. Our elderly are at a higher risk of hypothermia. Why? Why is our elderly at a higher risk of hypothermia?
Skin?
Ventilation.
Okay. So do they have a lot of physiologic reserve?
No.
Nope, they don't. And our elderly have some of those conditions that I talked about earlier, cardiac issues, poor perfusion or poor circulation. And for all those who thought that alcoholism, when you're out there drinking to stay warm, that's a risk factor for developing hypothermia, because now you think you're warm, so you stay out there shorter or longer. Yes, exactly. Taking medications that affect their ability to compensate for changes, and those that have social isolation. That's why elderly are more at risk of hypothermia. So they can end up with kidney failure, gangrene, severe infection, pneumonia, rhabdomyolysis, hypoglycemia, cardiac dysrhythmias. This list goes on and on and on. For kiddos, now this is interesting. For kiddos, if they drown in cold water, so say the water that they were in was cold, then their body actually starts to shut down, and not in a negative way, but it's more of it's only going to use what it needs to survive. And this is the reason why, if you have a situation like that and you can't pronounce them until they are warm and dead, because it may have preserved those organs by being hypothermic. And if you think back over the last 10 years, there are some conditions for which they will put them in a hypothermic state to kind of rest those organs so that they can heal better. Just food for thought. How do you know you have frostbite?
You can feel and see it.
Okay. So your fingers or your nose or your toes or whatever, they're numb, they're tingling. Ears is nose and tingling. And if it's what's the word? If you have paresthesia and it's stiff while the part is still frozen, then that's frostbite. And when you unthaw it, or as you slowly warm them up, then it starts to hurt. So, just kind of know your signs and symptoms related to that. Your book clearly gives some degrees of frostbite, like a 1st degree, 2nd degree, 3rd degree, 4th degree. 4th degree obviously is worse. That's necrosis and gangrenous tissue. 1st degree is kind of superficial redness, some swelling, no blisters. There's no mottling of the skin. There's no gray color to the skin. It's just kind of red and swollen. 2nd degree, it's red and it's swollen, but we have blisters. Should we burst those?
No.
Did you ever rupture a blister?
No, never.
Absolutely not, because now you're opening up a source of where infection can set in. So we have blisters. It's white or yellow. It can turn purplish blue when you start to thaw it out. 3rd degree is pretty much the same redness. They have edema with blisters. However, we have the vessels that start to rupture and they start to become black. So that's where you get deep. And then when you unthaw the tissue, becomes they have a lot of deep burning pain when it's rewarmed. So make sure you review that in Lippincott when you're looking at frostbite. And here's something interesting. If your face is involved, the cornea will actually have pain. No. Let's see, what else I'm going to talk about. When you have moderate hypothermia, that patient will they will be unresponsive, cyanotic, bradycardic, hypotensive, slow reflexes. And if you're doing cardiac arrest therapy on them, if they go into cardiac arrest, that may be because at that time, if they're shaken or jarred, it would be easy for whatever their bradycardic rhythm to kick over into a lethal rhythm. So those folks you want to kind of handle gently. You don't want to, just be blopping them around and making all kinds of quick motions and movements with them. At 82, they do appear dead. There's no pulse. There's no heart sounds that's audible. Skin's very cold. They're areflexic. Their pupils are fixed and dilated. Okay, you can't fix that. Pale, but if it's not severe and it's kind of mild, when we're looking at pale, cool skin, tachycardia, tachypnea, etc. So there is in Lippincott a comparison of hypothermia from mild, moderate to severe that kind of gives you signs and symptoms that you would see. So make sure you look at that. Okay. Diagnostics, basically a CBC and liver functions test. Like your lipase, we're going to get glucose, we're going to get ABGs, and then we're going to also do electrolytes. If we have a leg or hand or something like that, then they may do soft tissue x-rays just to see if there's any underlying trauma, or they may get a Doppler study to see if there's, have pulses or what the extent of the frostbite may be. Perfusion scans also, they'll do that to see if they have any perfusion scans. There are some ECG changes that they may have, bradycardia, AFib, VFib, which wouldn't be good. They may have T-wave inversion. So you will, as you go throughout the course, they're going to, and even on NCLEX, they will ask about ECG abnormality. So don't just look over and say, oh, they'll never ask that. That'll be something that they will ask. So ABCs, airway, breathing, circulation, prepare for resuscitative measures if need be. Remove all the wet clothing, do supportive care and measures, passively rewarm or actively rewarm. And passive rewarming is like warm blankets. Active rewarming is when we do humidified, warm oxygen, warmed IV fluids, warm irrigations, a warming blanket, those types of things. That would be your more active rewarming. And then until they're better, we're not going to feed them. So are we going to rub a frostbitten area to try to warm it up? You know how sometimes you rub your hands together?
No,
So if you
you
have
can't
a
do that.
frostbitten,
No.
extremity, no, we're not going to rub it because that's actually going to aggravate the damaged tissue.
Yeah.
So we don't want to do that. If they're septic, then we'll give them some antibiotics. If they have an infection, we'll give them some antibiotics. If they have hypoglycemia, then we're probably going to give them some IV D50. And that's only if needed. What if the frostbite is so bad that they have to go to surgery? So there's a couple of options for frostbite. So they may do skin grafting. They may do a fasciotomy or an amputation, depending on the extent of the tissue damage. And if it's in the eyes, they may end up doing corneal transplant. But we take off all clothing, all constrictive clothing, all jewelry. We do all of that. Okay. Anything else you can think of about hypothermia? More than what you ever wanted to know? Hey, this is the difference between, when, RNs and other healthcare professionals, whether you're physical therapy, RT, LVN, it is a lot. This is why I've been trying to stress this earlier on, start digging into this stuff so that way it can kind of, sink in. And then at the end of your chapters, there's usually some questions and things that you can do. So I would start reviewing that. So this is kind of what they learn in first semester to help, get them to understand about body temperature and, how all that works. Best thing to do if you're going out into the cold is to dress in what?
Dress what?
So if you're going out in the cold, how should you dress? You know,
In layers.
halter tops and short pants.
No.
Dress appropriately.
Dress in layers.
Dress in layers. So that'd be like a t-shirt. So for women, like a cami, then a long sleeve shirt. It could be a turtleneck, then a sweatshirt or sweater. Then you have a jacket, gloves, hat, mittens, you know, earmuffs, but, you know, warm shoes, closed-toed shoes. So it, you know, those types of things. Avoid smoking because smoking constricts the nicotine that's going to constrict your vessels. Avoid alcohol that causes you to stay out there longer. You know, if your clothes get wet, you got to take those off because all they're going to do is freeze and you're going to freeze in it. So, you know, 2 weeks ago when the whole country had that whole big, you know, swoop of Arctic air, that's what I'm going to call it. They was talking about the vortex come through. People in the upper portions of the states, they were leaving their pets outside. Now help me even understand that. And, you know, their animals, they were like frozen in position. So that makes no sense. So think smarter, not harder. But people do the same thing, you know, if their heat goes out, you know, some people have tried to do the electric heat, you know, where you plug it in and all that, you know, just safety in all of it is the best thing, best key. All right, guys, any other questions? I think I covered it all. Your thermal, your diabetes, we had already did Addis's and Cushing's and thyroid and hyperthyroid in class, so I think we're A-okay.
Sounds great.
Ms. Hudson, I have a question, but it's not related to what you just went over.
Okay.
For those of us who haven't regained access to you in Blackboard, who do we contact for that?
What do you mean, babe? Because I added everybody as
I'm not talking about as far as email. So we when we first started, this is for the repeats. Ms. John said that we would be able to see the lecture course in Blackboard, but we are still unable to see it. I sent her an email 2 weeks ago, and she said she would check, but she thought.
Has it come up at all on your course board period, or
I'm so sorry.
No, you're fine. So when you go to eCampus, do you not see RNSG 23? I mean, sorry, or
1324?
Yeah, 13. Help me out.
No, not anymore. We do not.
We can't see anything.
Okay. Let me, I'll be on campus anyway in the morning. Let me check with Dean Becker and see how to facilitate that. And then I'll have an answer for you on Tuesday.
Okay, awesome.
So you don't have any access to the PowerPoints or anything?
The only thing we can see is on the nursing page. I forgot what that's called.
Community.
So
community.
So basically a general, but so do
That's
you
right.
at least, okay. But when you, let me see, I'll go, hold on. So you can see community.
That's it.
That's correct.
Okay.
But that's it.
All right. But even so, hold on. I'm seeing if I can log on without having to go through a whole bunch of buffoonery. All right. Perfect. So I'm going to share my screen. So hit share and we're going to share that. Okay. So can you see the Blackboard, or can you see where it says Blackboard or your online classroom?
Not yet. It's black. Oh, yes, now. Yes.
Okay. So community, it's going to take a minute because I have a lot of stuff open. Let's see. So you should be able to see this here. Okay. So you can see all of this on the left-hand side, correct?
Yes.
Okay. So when you go to, it's transitions. So when you go here, do you have this folder?
Yes, we have that folder.
Perfect. So if you have this folder and if you're trying to get access to your PowerPoints, now the one that I did today was nope, the second semester. Go back. Go back. All right, so when you go to first semester, looks like somebody has a question. Oh, hold on. Okay, somebody says we're actually listed as guests, but we still cannot see the class. Got it. But this is what I'm asking here. So there are no PowerPoints. Got it. Because there's nothing here about the thermal regulation or anything. Okay, so when you were in the class, did you download those by chance? I'm just gonna ask.
I downloaded a lot of things, but I know occasionally there's things that are updated that may be put in the course, but not in this community.
Got it. Okay. Let me get with Dean Becker to see what we need to do. So if you're, I mean, you know, how to work this out, I guess would be the best thing to say, because some people do have access and some folks won't. But I think kind of and I don't know, I'm just basically now speaking out the side of my neck, so I don't want anybody trying to hold me to this. This is just a potential guess. I'm not saying this is fact. That what may have happened is they may have anticipated that you might have made, you know, downloaded the PowerPoints previously, etc. So I will talk to both Mrs. Johns and Dean Becker and see how, you know, what we need to do. Because I don't know how to facilitate that for you. If, you know, I know that you're on as guests, but I don't know if, you know, if that's supposed to be different. You know, I don't even know if you got changed to student, if you would still be able to see it. Does that make sense?
Yes, it makes sense. What Ms. Johns told us during orientation was that we're supposed to wait like 12 days or something like that after school started to be re-added. And like I said, when I emailed her the other day, she said she thought we would have been re-added and she was going to check, but she never got back with me.
Okay. Let me find out for tomorrow, and then I'll have an answer for you on Tuesday. So that way, if there's something that needs to be done, then, you know, we can take care of that and make sure you guys have access. I think the reason why they may not have had you on as students, because they have to have a count of people that have paid for the course on the 12th class day. It's a college thing. So all colleges do it. You have to certify roles and so forth and so on. And I think that may be the reason why. And if so, then I just need to know what I need to do to fix it, so that way you'll have access.
Okay, thank you.
Okay. Any other questions? Oh, oh, I thought she had a question. All right, guys. And you don't have anything else to ask me, then we will do comfort and clotting on Tuesday.
Thank you so much.
Thank you.
You guys sound so thrilled. You're like, okay. So,
Thank you. See you on Tuesday.
All right. You're welcome. And I think I have some case studies for you as well. So I'll try to send those out for you to kind of look at, and then we can kind of go through them and talk about some things just like we did. Okay?
Sounds great.
Thank
All
you.
right, guys. Enjoy your Sunday. Stay warm.
Ms. Hudson, how will you send them out? Will you email them or what?
I will email them. So
Okay.
just get your emails fixed. I mean, the college, we've had difficulty trying to validate if we send stuff out. So the college has gone to, if your email is not DCCCD, we're not responsible for whether you get it or not. This is why we tell you to change all your stuff over. And I know there was a young lady that was concerned about the whole Outlook thing. You can add it on as another account. So, you know, that way you have what you need. But you shouldn't have to re-download it. You just add it as another exchange. And if you go to the website and type in how to add, you know, Outlook to your iPhone or Samsung or whatever you have, then it'll get it for you. Okay?
Okay.
It got super quiet. I was like, all right, guys, see you on Tuesday.
All right.
Okay.
Yeah.
Thank you.
Okay, bye-bye.
Bye.
Bye-bye.
Bye-bye.